My subject today looks scary, Atlanto axial instability, but I'm not going to speak from a deep surgical point, but because, as I said, it looks scary, it is actually. It's just to direct the attention of the doctors and people who work in the field who can see the Down syndrome people, children, our lovely children. Those children usually are really very social, very active, very sportive, and they might be exposed to risk. Fortunately, it is not a high risk. It represents about 1 to 2% of the children with Down syndrome. So this problem can be addressed, can be prevented, and we can prevent a life risk problem if we take care and have a good screening, which I want to focus today about how to catch those children who has this problem and to prevent the injury. Okay, as we heard in the morning that the Down syndrome children usually are lax, hyperlax even. This is a big problem in all the joints of the body. But when it comes to the cervical joints and cervical spine, it represents a problem really, because here the axis, the atlas is this bone, and the axis, the bone, and the second cervical vertebrae with a dens between. Here we can see the atlas goes around the axis, articulating with the dense bone. This allows the rotation of the head. When there, and these two bones only actually held together by a number of ligaments. When these ligaments get lax, which is normal among the children of DS, then there will be a problem if they go in flexion and extension. There will be almost no problem in rotation, but only will be in flexion and extension, as this bone, which is the atlas, goes in this direction and compress here the pink color, the spinal cord, which causes immediate compression on the spinal cord and affect the respiration. So the Atlanto axial instability, as you said, is a common feature among the Down syndrome. If this instability is significant, it causes or it represents a risk of injury, and then those children cannot or should not do sport or activity, hyperactivity sport, because they will be at risk, and it is our job to see those patients, those children, and prevent them from injury. So the laxity is common among all the children, but fortunately, 80%, 85% has no symptom at all. Only 13% of the children, they have some radiological manifestation when we do the screening, but they still have no symptoms. Only 1 to 2% have symptoms, and those will require treatment. So what are the symptoms? Actually, very few will complain. The children with the Down syndrome usually do not complain too much. So they might have some neck pain, They always walk with the tilting head forward like this, because that relieves the spinal cord and give them some sort of pain relief and better breathing. By time they get muscle wasting, they might get improper gait, and they start to, the parents usually notice that they start to walk like a waddling gait, and they have some trembling in the legs. They might get some sensory changes in the hands, like pins and needles, or numbness, or tingling, or loss of sensation in hands and legs, and they also might lose control of urine and stool. Sometimes they lose some hand skills, like covering the pen, for example, or holding a pen or making a draw or something. They might lose these hand skills, and the parent should notice these changes. So clinically, as any examination, it depends on the history, the examination, and some imaging, but history, it depends always on the parents. It's very important. The parents should they should notice their children very well and do every detail, and tell the examiner or tell the doctor about the questionnaire they have and the problem the child has. Then the examination should be done by somebody who has a good knowledge about the neurological examination, because the examination should be really a meticulous examination, very detailed and very accurate, to know the history of this examination before and after an accident or an injury. And the screening, depends mainly on the X-ray, but sometimes we need a CT scan and MRI. The X-ray is important, the lateral view in neutral position. We see here the axis vertebra and the position of the Dennis, and here the atlas. We do it in flexion and see if there is any interval, and we do it in flexion and we see if there is any interval. The normal Atlanto axial interval in children with Down syndrome is about 5 millimeter. In normal children is less than that, but up to 5 millimeter in Down syndrome is accepted, because, as we said, there is a laxity in the ligament. So we see here again the X-ray. This is the open mouth. We can see the axis and the Dennis here, and this is the atlas. We see the edges here equal, and we see the interval here, which represent the letter A here, is equal. So this is a normal one. We can see in the MRI also here between the Dennis and the vertebra, the atlas. And we can see here this space, if it is constricted or compressed. And here sometimes we do a CT scan. Actually, during the screening, we classify the children to 3 groups, or we do the screening in 3 groups of age, between 5 and 8. This is the age which can show something on the X-ray. Before that, there is immature bone and we might be misleaded. The second age is between 10 and 11, which is a growing age at this time, especially for the Down syndrome. It shows, by statistics, shows that this is the age which make the real adolescence age for them, and 18 years after complete growth. And we want to see the difference among these three groups. So the X-ray for less than 3 years, as we said, is not helpful as the growth of the skeleton is not well enough to diagnose such cases. So we depend on X-ray on the lateral view. AP, it gives some information, but it's very difficult for the child to cooperate for open mouth view, so we depend on the lateral view in flexion, in extreme flexion, extreme extension, and the neutral position. Here, if for the treatment, actually, mainly is conservative or non-operative treatment. We look at the interval, as we said here, this space between the Dennis and the Atlas. If it is more than 5 millimeter and less than 7, usually if there will be no symptoms, and if there's no symptoms, but this is a hyperlax and might cause some risk, then those children should be stopped from contact sports like football, basketball, rugby, American football, and should avoid high jump and avoid diving also. If the ADI, this interval between 7 and 9, this is a moderately unstable, and this usually has symptoms, and then we have to observe those children, and if they do activity, we should keep them always having orthosis or a collar, and they should absolutely avoid contact sports. If the interval more than 10 millimeter or 10 millimeter and above, then they need to have fixation, fixed fixation, and usually we do it with external Minerva or frame in this position. And those really at high risk, then we should prevent them from sports. The surgery is not easy, especially sometimes when the child comes to us is too late. There is subluxation or dislocation of the Atlanto axial joint, and it is fixed. In such case, we don't try to reduce it because it's very risky. We just, we just do a laminectomy and remove the lamina from the back and make this canal wider and fix it in this position between the occiput and the second vertebra. And this is a very risky and complicated surgery. Should be done by people who has experience in that. Fortunately, it is very rare. I don't know if we have, do we have here any anesthetist? No anesthetist here? Any anesthetist? No anesthetist. This problem, you know, this Down syndrome children, they are exposed to many surgeries, and as we mentioned in the previous lecture, like the adenoid or tonsillectomy, and they have many problems exposed to surgeries. So we have to, inform or the doctors, the anesthetists should know that this might cause a problem and a real risk for the children when they go to any surgery because of the intubation. And usually in intubation, we put the child in hyperextension, and we might expose them to high risk and complete compression of the spinal cord, and they give them a problem. So all anesthetists should be aware of this problem. And this is a very nice book having all the hints what to do with, for the anesthetist, what to do with a Down syndrome child and how to take care before and after and during the surgery and during intubation. Again here regarding the sports, I just want to tell that they are very active and very social people, and they love to go into sports and go among the children to play and show their ability to do things. Actually, we should encourage them. We should not stop them from doing sports, but we should take care for the risky one from contact sports, especially in American football, which is getting spread more and more here, and rugby also, jumping, diving, and contact sports like football and basketball. Other activities, they can go with observation, and they should be allowed to do sports. I think I finished. This is some references for one who wants to get more information. And again, thank you very much